The day I was diagnosed with diabetes is a day I will never forget.
When I was diagnosed, I was just 15. I was like a teenage girl. I wanted to go out with my friends, enjoy life and explore and expand. And diabetes made life very limiting.
Since I was initially diagnosed, my life changed radically. My parents were shocked and they decided to hide it from my relatives and friends.
I knew nothing about diabetes, didn't know what was happening in my body. Why am I feeling like this? Why am I not well?
Diabetes was something that I knew of and ran within my family, but it was something that was a big change for me. And I think I took it seriously for a short time, and then it just kind of went up and down over time.
Definitely felt embarrassed by diabetes. I'd say in that age range of sort of teens, definitely, that was the hardest part because it was a fear of being different and I always wanted to be the same and I wouldn't want people to know about it.
Eu senti que era desafio diário, desafio para ser aceite.
Living with diabetes can be a challenge, you know, thinking about it all the time and it's always in the back of your mind.
Diabetes is almost like a permanent newborn where you constantly have to give it attention. You don't get a break from it, it's 24/7, so you're constantly thinking about what actions and things would impact your sugar levels and how that would make you feel.
Diabetes changed my life totally because I had to change my eating habits, the way I eat and when I eat.
We are all aware about the 5 pillars of diabetes management, being medicine, meal planning, monitoring, and movement. And the 5th one, which is the most undermined, is mental health.
Living with diabetic complications has changed my life altogether, which is not an easy. I am always in a fear to travel alone.
I think for healthcare providers, there's too much to talk about. And so when you see a healthcare provider, they're really monitoring your numbers.
É muito importante a família estar presente, é muito importante a família aceitar. E são os primeiros a quem nós recorremos, nós que temos diabetes, a quem nós recorremos a pedir ajuda, a pedir apoio, abraço.
In 23 years of living with type 1 diabetes, never was I screened or never have I seen anyone being screened for diabetes distress or burnout.
Having all my family and my friends around me that have always been supportive and always helped whenever I've needed it, whatever it might be, it really helps. And
I developed eating disorders a few years after my diagnosis. I got very confused and frustrated, so I went on the internet hoping to find some answers. And that's when I realized that there's not much information available in my own country, and I wish it could have been different.
I think what it is about dealing with this disease is that it takes a lot of support. The people who support you, who you can talk to, who you can learn from. This is peer-oriented. It really makes a huge difference.
Diabetes care improved my life a lot. At first time, I was not aware of about a healthy life, but after coming under the treatment as a type 1 diabetes, I got counseling and education, health education, diet education, and motivation for a quality life.
Well, first of all, I'm so proud to say that I have reached 68 years old, and I'm feeling wonderful. Women of my age face a lot of challenges. The first one is the physical and the mental complications. You know, aging brings health issues, chronic illnesses, and sometimes cognitive decline. We are so prone to arthritis, hypertension, diabetes, cardiovascular diseases, and the foundation of all of those chronic conditions is healthy eating and physical activity.
Es un proyecto, pero es un proyecto, es un armado. Bueno, hoy me voy a cuidar más que ayer. Hoy voy a tratar de caminar más que ayer.
By having a physical exercise routine makes me more healthy by improving my overall health condition. It helps me to lower my blood glucose,
helps me to reduce the chance of having cardiovascular conditions or renal impairment.
Access to diabetes care has given me absolute freedom to live my life and to be as healthy as possible for as long as possible so that I can just have as much time here looking after this little one and watching her grow up.
I think for me, I'd put on a lot of weight. So I think just being able to lose a lot of weight has just given me that energy back so I can keep up with my young kids.
Dear colleagues, friends, ladies and gentlemen, I'm Dr. Akhtar Hussain. I'm the president of International Diabetes Federation. It is my utmost pleasure and an honor to welcome you all in this very event. We will have, first of all, we'll have a kind of ministerial expert panelist who will be talking about the well-being. As you have seen that diabetes is not only blood glucose. Diabetes is a human. We should be thinking of patient-centric, not glucocentric. So whenever we are thinking of, in clinical training, we learn about glucocentric approaches, that how we control the glucose, but we often forget this is have a kind of well-being of a patient like all other human beings, nothing exceptional, that this is also a very fundamental thing for, so this is the primary focus. So I thank everyone, as I said, that particularly the panelists and the people in the room here, that you are here. At today's event, we'll be speaking about diabetes and well-being, which is the theme of 24 to 26 World Diabetes Day campaign. As we have just seen in video, featuring testimonials from our extensive network of people living with diabetes, the condition has a huge but often underappreciated impact on people living with the condition and their carers. Today, we'll discuss what different stakeholders can do to make sure people living with diabetes achieving well-being regardless of where they live. I would like to thank IDF partners that have supported us with unrestricted grants for activities. I would also like to thank the people who are online joining us. I'm very proud to say that we have about 2,000 people registered for this event online. So it shows the interest of diabetes community on thinking about the well-being. So it is my pleasure to introduce an opening statement by the WHO Director General, Dr. Tedros, who could not join us today in person, but sent us a video message. So you will be watching Dr. Tedros, the Director General, addressing the event.
Distinguished guests, dear colleagues and friends, as you know, diabetes is one of the world's leading causes of death. And in the past 20 years, deaths have risen by 70%. In many regions, accessing treatment and services poses significant and urgent challenges. People with diabetes also face stigma that can impact their mental and physical health and prevent them from seeking the health services they need. It's time to adopt a holistic approach to preventing and managing diabetes, which supports the physical, social, and mental well-being of people living with diabetes. The WHO Global Diabetes Compact emphasizes the vital role of people living with diabetes and diabetes associations in tackling stigma and promoting action. Today's event showcases what countries are doing to prevent, detect, and treat diabetes. Thank you all for your continuing commitment to creating a world where every person, including people living with diabetes, can thrive and lead a life of dignity and well-being. I thank you.
Thank you, Director General, for your kind message and the interest you have always shown in diabetes. I would now like to invite the ministerial speakers who are here to, I'm introducing Honorable Minister Kailash Kumar Singh Jagatpal, is Minister of Health and Wellness of Mauritius, Dr. Mohammad Al-Thani, Director of NCD Prevention Program, Ministry of Public Health of Qatar, and Dr. Martinez Guetres, Head of the Disease Prevention and Control Division of Ministry Health of Chile, who will be joining us online, and Dr. Bianca Hemmingsen, Medical Officer, WHO NCD Department. So everybody will have a 5 minutes presentation from your country's perspective, and followed by some questions that I will be asking, so that you can tell to the audience before the audience will be allowed to ask you a few questions. So this will be the order. Now, first of all, I would like to give the floor to our first speaker, Honorable Kailash Kumar Singh Jagatpal, Minister of Health, Wellness, and of Mauritius.
Thank you so much, Dr. Akhtar Hussain, the President of the International Diabetes Federation. Excellencies, ladies and gentlemen, a very good afternoon. It's a pleasure for me today to be with you, especially when we are talking a topic that is in all that interest for all of us, that is diabetes and well-being. A little bit an outlook of what is Mauritius. Mauritius is a small island. It's an island in the Indian Ocean. An island, it's more than 12 hours flight from here to Mauritius. It means quite far. The population is a migrated population for no more than 2 centuries now, coming from Asia and coming from South Africa, and very, some population coming from Europe as well. The Mauritian population, for the time being, it's an aging population with now presently more than nearly 20% of the population being above 60, and in the next 20 years that will keep on increasing, and the number will reach 30%. The NCD status, around 20% of the population is diabetes, and another 15% being pre-diabetes. And we've been doing a 5-year survey. NCD surveys been done in Mauritius since 1987. And what we've noted compared to the last surveys done in 2021, there is a small reduction in the number, in the percentage of diabetes. That means that previously it was more than 20% of the population suffering from diabetes and 20% pre-diabetic. Now, for the last 5 years, that number started decreasing. Now, what has been the government approach towards this problem is, first of all, a lot of communication campaign been ongoing around the year. So exploiting all the possibilities, it's not only for the Ministry of Health, involving the NGOs, involving the different stakeholders, Ministry of Education, so trying to at least giving a whole picture of what is diabetes and what are the consequences of diabetes. So that has been ongoing for the last 20 years now. And also, that is the primary detection. That means a lot of screening being done at the community levels, at the different levels, so that we try to pick up even at the workplace as well. So it's very important that we've been engaging the population of understanding, doing the screening, and also giving a free healthcare services. At present, you've got a dual system of healthcare, that is a private and the public sector, where the public sector accounting for more than 75% of the population's health needs, and the other 25% being in the private sector. Now, what's again is being done, there's a lot of screening instrument being used to detect the complication of diabetes. For example, retinal screening being ongoing in the different levels of the health services, screening for retinopathy, screening for all the vascular problems is associated, and the cardiac problems associated with diabetes. So that has been ongoing, and also trying to give as much as the country can afford for those who are having a lot of complications, with the renal complications. We've got a renal dialysis unit for a population of 1.2. Currently, more than 1,500 patients been doing the dialysis, and it means whole of these patients, mostly they are diabetic patients who have got renal damage and so on. So that has been the progress, but yet there's a lot to do. So in terms of what is, again, the government strategy to fight diabetes, so there has been quite some regulation also being done at the level of, for example, regulation on a tax on sugar. We've got more or less, you've got regulations on fatty acids, for example. And so these are regulations being met to try to cut down the, the sugars that we have in our food. And at the same time, there is also the cigarette and alcohol. If I will tell you for the time being, if you consider the age group, according to the recent report, from 24 years to 34 years, so that youngster group, more than 50% being a regular smoker. So taking all these considerations, government is driving the diabetes, controlling the diabetes, and at the same time getting the support, especially from World Health Organization and other organizations, trying to give the capacity, building the capacity, and trying to organize, find out what's not working on, and getting up to things that's been done. Over here, there is a lot of budget also required, and you know how after the pandemic, so everything is becoming a priority. Public health is a priority, and cities is a priority, and now you will see in the coming years, climate change is going to be another priority. So it makes quite, very difficult to navigate in this troubled seas and finding how we can do better for the control of diabetes. I'll stop over here. Thank you.
Thank you. Thank you, Your Excellency. I had the opportunity to be in Mauritius when this data was presented. And it is really encouraging to see that the kind of data that they could show for the last 20 years is rare in a developing countries setup. So Mauritius is making an example, and the data are showing there is a slight decrease, and which is the first time that we are seeing any of that sort. Thank you. And now I will introduce Dr. Mohammad Al Thani, the Director of NCD Prevention Program, Ministry of Public Health, Qatar. As we know that Qatar has the highest prevalence of diabetes and the Gulf states. And we'd very much like to know that your role in your position, that what you would see, what are the challenges, and how do you tell us that how the world can also learn something from you. I know that Qatar has done many things that we should be learning, so we'd like to hear from you.
Thank you, Dr. Akhtar. Dear all, Assalamu alaikum. I'm Dr. Mohammed Al Thani from Qatar. As you know, I hope that everybody knows Qatar after the World Cup with the end with Messi and Mbappe. And if you don't know it from World Cup, I would like you to try Qatar Airways and come to Doha and see Qatar by yourself, just to know. I know, again, I like Dr. Maurice, His Excellency, we are a small country again, but we have big dreams and would like to be added value around the world. So, Dr. Akhtar, as you can see, Qatar is having clearly a challenge in diabetes because we were one of the highest, not the highest, but one of the highest countries in diabetes. And this is logic, the GCC is one of the countries that lived for hundreds of years, maybe thousands of years on the trace, little food, and they are all eating much less, and suddenly they have all the food in the world. So what do you think about this, and living in the rural areas to cities full of this stress? So this something happens. So it's shocking us in Qatar that we do a lot of biobank, testing, and we know that the genes of diabetes above 50% in the Qataris in Qatar, which give us a challenge, clear challenge that it is there. We have diabetes 1 and diabetes 2. Both are challenges. Diabetes 2 even start earlier than what we thought. So this is the reason that diabetes is becoming, we are investing, and most of the GCC countries, diabetes cost in the primary healthcare around 40% of the total cost of the primary healthcare is only for diabetes and the complication of diabetes. So it's becoming very serious that any action in diabetes, if you lower any action, effectiveness for the people or efficient the cost, you will be doing a lot of job if you can find something that is really effective in this part. So what we are hoping in Qatar, usually we take things seriously. We work on strategies. We are the first country in the region to put the Vision 2030 before the SDGs. We did 2 strategies, and now we are going to the 3rd strategy. And part of this, we started a lot of diabetes as early as possible work, in 2011. And now we have a center for diabetes and metabolic disorders, connecting diabetes and all the other metabolic disorders in one place in our biggest hospital in Qatar. Even we have, association, the Qatar Diabetes Association that work with you to make awareness. The thing that Qatar make it, may be special now that we are connecting in the coming year. We connect all the system in Qatar in one data exchange system. So we have before Cerner to connect the hospital and the primary healthcare. And now by this system, we can make everyone know every patient practice. So we have guidelines for diabetes, but to make sure that everybody is doing it properly. And we are looking forward with partners around the world to see the best guidelines to make people live longer. We want to compress morbidity. We want people to have delayed for them, and it happen, not to have with strong complications. As you can see, Qatar has been taking things seriously and achieving, like we started road traffic accidents 15 years ago. It was 26 per 100,000 deaths. Now it's on less than 6 per 100 deaths, so we lowered 82%. We did the stepwise survey. Morbid obesity was 9%. Now it is 5%, almost 50% down the morbid obesity. So now we are tackling diabetes more, and we're giving it a lot of dedication. We have, like you said, 2,000 people. We welcome the 2,000 here with us. We do a seminar every 3 weeks in Qatar for people around the world. We have around 1,400 people attending this seminar every 3 weeks. New thing about diabetes, to be oriented what's happening about diabetes. Now with this new system, we are trying to take care about every patient. Qatar, as head of the National Screening Committee, we approved that yearly diabetes National Screening Committee will be free for everyone. Like most of the health in Qatar is free, but we'll call people to come to remind them to do a diabetes or any different blood test to assure how much they are growing in this challenge. The problem, as you mentioned, Dr. Akhtar, is a lot of mentally. Even in Qatar, people are sensitive, they are living in peace. When you tell them you are diabetic or your son is diabetic, what a pain. Nobody can feel this pain. The worries about your son or yourself, why it come to me in early stage and how I would navigate. Can I have this challenge properly? So we want a lot diabetes to become a very friendly for people. So you got it, yes, but you can survive with very normally as much as you can, because people will die sooner or later, but at least they live full dignity, enjoy life as fulfillment in a healthy way. Regarding life expectancy in Qatar, although we have diabetes, around 16-70%, but still people will have good life expectancy. And the new strategy want to go from 83 to 84 and from 82 to 83 and a half in the new life expectancy, and part of it to control these diseases. Qatar have very low number in communicable disease, deaths, and low number of road traffic accident. And now diabetes is the most thing that we are putting research on. And we are hoping that with the partners in the world, we can keep finding more effective ways. And this with the new technology, we need to see how much AI can help us. We see how much they've approved watches and the Internet of medical things, how it can help us to grow. And this is a field that we would like here to have something and discuss these things with you. And thank you for that. Thank you.
Thank you. It's so encouraging to hear, Dr. Thani, that what you are doing in your country. Qatar has made many examples, and I think that we, as diabetes community, we can learn also much. I would like to mention that one thing that we must not forget, even though we are focusing on the life of a person with diabetes, that which is not only a glucose, but we must not forget that we must work that people don't become diabetics. And that is the prevention part. And this is one thing I always remind you that unless we stop the inflow of the incidental cases or the new cases of diabetes, we at one point, every society, no matter how rich or poor, will fail to tackle the number of people to provide a kind of care that also encompasses a human, that we are focusing the well-being of a people with diabetes. So I will urge excellencies, the friends, the colleagues, that everyone, that we must not forget the prevention part while we are talking about the good quality of life with diabetes. So with these words, I will now say that whether we can get reach of Dr. Martinez Guterres, head of the Division of Disease Prevention Control, Ministry of Health of Chile. So let's hear from South America.
Hello to everyone. Can you hear me? Yes. Okay. So thank you very much for the invitation. I represent the Ministry of Chile in this reunion, and I wanted to tell you a little bit about diabetes in Chile. We have been seeing a rise in the diabetes prevalence. We are now at 12.3%, which is very worrying for us. But we have seen, and that's very interesting, we have seen a decrease in the rate of mortality for diabetes from 14.39 to 9.54 in 10 years. And I think a lot of it has to do with the main program that we have in Chile, which is a guarantees in health program, who actually guarantees the diagnosis and treatment of diabetes and other health problems such as hypertension, renal insufficiency, and HIV, etc. So we have 82 at this point that are guaranteed for the whole population, and that's, I think, very closely related to the decrease in the mortality. We have a plan of an action plan of non-communicable diseases that goes from, like our host was saying, from prevention to rehabilitation, the whole comprehensive continuum of care. And it focuses strongly on promoting healthier lifestyles through physical activity and a healthy diet. Stop the acceleration of the overweight and obesity in childhood and adolescence, and improve the population's knowledge about prevention and control of the NCDs. We have a very extensive primary healthcare network, and in that primary healthcare network, what we do is we do preventive health checkups, screening for adults and senior citizens that include actually diabetes screening, and so that's the way we ensure that we get the diagnosis, but also then the guarantees programs kick in, and we have the access, the guaranteed access to treatment. We also, in primary healthcare, what we do is we have a strategy that is a person-centered comprehensive care strategy, which takes the patient as a whole, and actually because before that we had vertical programs. We have the diabetes program, the hypertension program, the mental health program, and in that sense, people had to come, for example, three, 4, 5 times to the primary healthcare center to get their care, because we were seeing them as separate sections of a person, but not really comprehensively. And so now we're doing that, and in that sense, we are promoting the well-being of diabetes patients with other health problems, and also taking, because we know that the risk factors of diabetes are the same, very similar to hypertension and other, and for example, cancer. So we are taking the patient as a whole in this strategy. And now Chile faces a lot of challenges. One of the most important is the increasing prevalence of obesity. So I was very interested in the representative of Qatar when he was saying that they decreased from 25 to 5%. That's amazing. That's really good, and we would like to know how they did it, because it's difficult to actually address that. We recently had a law that required for all foods to have some like stop sign saying high in calorie, high in sugars, high in salt, and that's been effective actually, but just in making the increase, stopping the increase of prevalence of obesity, but not really decreasing it. So for us, it would be very interesting to know that strategy. And the other thing that I think in terms of well-being, we need to do is actually increase access to new technologies. So, for example, there's a lot of new technologies like this device that you put in your arm, and you can have the measurement of the glycemia and actually your treatment, which is for now not a possibility for us to guarantee for the whole country, but we would very much like to increase access to those kind of devices, and also new technology in terms of drugs, diabetes drugs. So I will leave it there, and then maybe in the questions we can talk a little bit more.
Thank you. It's so interesting to hear so many encouraging words from so many colleagues and excellences, and I would also like to say that many people are taking also this, not only this diabetes, but also the cardiovascular and renal. And as you know, that IDF also produces guidelines. So this guideline, the new guideline is coming up within the end of this. And we are putting one particular chapter on cardiorenal protection for people with diabetes. But we are introducing a new concept that is glucocardiorenal protection. Because for about 40% of the people with diabetes have the cardio and renal problems. So we cannot forget glucose. So therefore, we are introducing the term glucocardiorenal protection instead of only saying cardiorenal protection. Thank you. And so now the last but not the least speaker from this ministerial panel is Dr. Bianca Hemmingson, Medical Officer, WHO NCD Department.
Thanks a lot, Actor. I don't know if this works. Oh, now here it goes. Thank you. Thanks a lot for the introduction, Actor, and also to your colleagues for arranging this event, and for all the intervention by my co-panelists. Thanks a lot. Yeah, as mentioned, my name is Bianca Hemmingsen. I'm the medical officer working in the World Health Organization on diabetes. Due to the increasing burden of diabetes, which you also heard from Dr. Tedros, the member states endorsed in 2021 a diabetes resolution. But ahead of this, we actually launched the Global Diabetes Compact in headquarters, which is an initiative where the objective is to increase access to management and also to enhance prevention of diabetes. It was quite timely because we launched this in 2021, April, which was the same year as the 100 years anniversary of discovery of insulin, and just 1 month after the resolution was endorsed. The resolution put a lot of requests both to the World Health Organization and to member states. For the World Health Organization, one of the requests was development of global diabetes coverage targets, which was developed and also presented at the World Health Assembly in 2022. The 5 targets, they're quite ambitious, but they're judged to be achievable by 2030. The targets are that 80% of people with diabetes, they're diagnosed, 80% of people with diagnosed diabetes have good control of glycemia, 80% have good control of blood pressure, 60% of people with diabetes above 40 years, they receive statins, and finally 100% of people with type 1 diabetes have access to affordable insulin treatment and glucose self-monitoring. In order to achieve the global coverage target as well as the objective of the Global Diabetes Compact, we have developed 6 work streams where our diabetes initiatives, they are embedded in. I will not go through all of them because I know we are short on time, but just to mention, we have access to essential medicine and associated health technologies, technical products, and of course also country support as part of the work stream. Finally, we also have the governance and partnership work stream, where I would like to thank a lot of you in this room and also probably online who have contributed to this, because in order to achieve the objective, we need to unite stakeholders. So we have consultations both with the private sector, people living with diabetes, and also several NGOs, and of course also member states. So I think that's all for me. Thank you, Actor.
Thank you very much, Bianca. We always get mixed up with Bente and Bianca. You know that. So that what you have done in the recent years is remarkable, and also our friend Goika. It started the journey from Goika while she was in the WHO, and so thank you what WHO is doing for people with diabetes, and also supporting us, and the collaboration that you have extended to us and to the other NGOs working in this area. The creation of this compact, which is a kind of unique thing that you are able to achieve. So I will ask you few questions. So I think that I will, because of the time limitations, so we'll have to limit some of my questions. But since we have this opportunity, so I think that I will raise some issues, but we should be we try to make it as short as possible, so that we have the others the sessions could end up in a reasonably late hours. So I would like to say ask a question. His honorable minister from Mauritius, that how can countries address the well-being of population, especially in countries with high NCD prevalence and in low resource settings?
Thank you. Yep. So to our understanding here, well-being is a state of content, is a state of happiness that we all have to individually, or it's a feeling that everyone has to get this feeling of state of content. Now, on one side, you've got the diabetes with all the different complication, causes, genetic, society transformations, that's a very important, cultural issues. And then at the same time, we are looking at diabetes. So this interface that we want to do, and as you've been saying, hearing, listening to all the speakers here, it's definitely if we keep on the track that we've been moving, yes, we've made quite a lot of progress. In other words, we've flattened the curve. But is it where we want to reach? Only flatten the curve, or at least we have to curve down the curve. So we've got to look at it that we need to curve down the curve. And looking at this, it means the well-being come into the center point. And how do we address well-being, especially in populations where diabetes have a very high toll? So it means that how do we address this? It's very important for us to look at it at the different population. For example, pregnant women following treatment for pregnancy, you've got to ensure that these women understand the causes. Maybe at one stage of pregnancy, you have no diabetes, but at a later stage, you've developed diabetes, especially where in countries where the proportion of diabetes is very high, because the consequences of a pregnant woman with diabetes, the outcome, we all know what may be the outcome. At the same time, looking at it at how, because in different cultures, we know how that's been going on. Do we speak about diabetes, especially from early age, early schooling, in school, education setup, university setup? So it's very important to put a lot of emphasis, because, in other words, saying it that practically in all families, in 4 family units, you will know somebody who's suffering from diabetes, who had some diabetes, a complication of diabetes. So it's very important for us to introduce what is diabetes and get it that the mainstream of our education, because from here where the wellness will come on. And anybody, be it you're not diabetes, probably yes, because at this age you're not diabetes, but at a later age, because of other issues and other problems, and you got the consequences of diabetes as a result of. So it's very important to introduce this concept of wellness in the population. Wellness will bring whatever, wherever you are, whatever, in the society you are. So understanding that wellness concept will obviously lead to people not suffering or having complication of diabetes to try to have a better life. I believe that should be the objective, and where this, this meeting help us to understand how we should bring forward this concept of wellness and diabetes. Thank you.
Thank you so much for your insight. And Dr. Thani, so first of all, thank you for correcting me that Qatar has not the highest prevalence rate, but one of the highest prevalence rate. Thank you so much. You are correct. I would like to ask you a simple question, not a simple question, that how can a national health system integrate mental health services into their diabetes care program? Do you want to, you can tell about Qatar, that what you have done in Qatar, but you can also say a little bit what you think, what it should be.
Yes, thank you. And this is part of what we are going to do. You mentioned mental health, and Qatar is welcoming everyone to summit, World Mental Health Summit in Qatar in next February. It's the first time to happen in the Middle East, and I would like people to attend the mental health. So part of the name will be digitalization and integration of mental health services. So part of it that diabetes and mental health service will be more connected in PHC, and people with diabetes will be assured that they are happy living well mentally, because sometimes we know in Qatar that diabetes is not only for food, it's from of stress and mental challenges in the system. So people have some problems, they get diabetes of high stress and mental imbalance. So we are working to invest in this one, and with our new mental health center, we are collaborating to put proper questionnaire and guidelines to connect diabetes and mental health. Other than I mentioned in diabetes, in Qatar we have taxes on sugary drinks. It was in soda, but now we're pushing it to be sugary drinks, plus we are doing it on a trans fat maybe, or the snacks that are already made. So tax is even helpful to work on this issue. But mental health, we believe that it is a reason. It's a reason, and we always discuss the sadness and the mental, but we would like to work together with our partners. What is the next big thing that we need as an indicator for every country to put to make mental health and diabetes aligned? What's the best thing that should we have like a paper or questionnaire to be finished in every health center, in every file of every patient about the mental health center? We can make like a formula to assure that these people, part of their problem is their mental problem. So this is the reason they have uncontrolled diabetes or they refuse to get the medicine on the right time. So we'd like to work with you on this matter to find the next thing, how to tackle this person, diabetes coming genetically or from food or mentally. And we should intervene here and give him more relaxed time to control diabetes. Thank you.
Thank you very much, because one of the things that we don't know, that I myself was interested in this particular area, and I think I started working, and we think we had some publications, but one thing that we have even established the link, the biological link between glucose and depression. And but what we don't know, that given an intervention on depression and diabetes will have a better effect on these glucometabolic complications, which we still don't know. That would be interesting to see. Anyway, I would like to move to Dr. Martinez Guetres, that which public health interventions has Chile implemented in the last decade in terms of physical activity and healthy diet to achieve physical well-being? Is this assessment satisfactory?
Yeah. Well, as I was telling you, we have been including a lot of, for example, well-being content in the schools. So now the curriculum has a lot of education for health. We have been also working on policy on structural factors that would actually confront this epidemic. So we would, as I was telling you, we did the policy for the stop signs in the food. We also have taxes for tobacco, for sugary drinks, and we also have been implementing programs in primary health care that have almost 100% of coverage of the population. So in that sense, is really a very potent tool to actually reach all those areas that may be underserved or maybe with that would have vulnerable populations. We have also been increasing our budget for promotion of health, for a lot of programs directly offered to people that have chronic diseases, and such as, for example, physical education classes, nutrition workshops for people that are in these people-centered program that I was talking about before. So we've done a lot of those things, but we still, in terms of at least obesity and sedentarism, we are still trying to achieve some policies that will give us a better result in terms of well-being for the whole population, and not only for people in primary healthcare centers and or people that have already the disease and are trying to improve their lifestyle.
Thank you so much. My last question would be to Dr. Bianca Hemmingsen. That is we all know about the targets. So what WHO is doing to make sure that diabetes targets are reached at a national level? Here I would like to say specifically low and middle income countries.
Thanks a lot, Doctor. It has a very high priority for the World Health Organization to support especially low and middle income countries to achieve the global coverage targets. And it's done through the Global Diabetes Compact that works both on the global level, regional level, as well as country level. There's several ways we're doing to try to support as good as possible. One thing is providing technical packages to integrate diabetes into primary health care. There we have the PIN package. It's a packet of essential non-communicable disease interventions in primary health care. And we also have the HEARTS package. Beside of that, we have specific projects in countries, for example, in Ghana and Uganda, where we support training of healthcare workers as well as ensure they integrate standardized protocols for diabetes and hypertension management. Finally, as a part of the Global Diabetes Compact, we are developing technical products. Therein, I just heard that you mentioned pregnancy and diabetes. That is one of the guidelines we are currently working on. Also, insulin management for type 1 diabetes, as well as a monitoring framework for monitoring of the global diabetes coverage targets. So we have different initiatives, but one thing just wanted to mention that even though we have those initiatives that I hope can be useful for member states, one thing that is needed is also political commitment from ministers of health to prioritize diabetes, to ensure that it's prioritized both financially as well. Thank you.
Thank you. Given the time limitation, I will not go for the second round of the questions. I think I will drop the second line of the questions. I may be taking, since one, maximum 2 questions from the audience. So as I said, that not more than 2 is not possible because we are already running about 25 minutes late.
Thank you, Mr. Chairman. Excellent presentations. We have a diabetic pandemic. I come from a country where we have a serious diabetic outbreak of diabetic foot and diabetic deaths, but it's not recognized. Same thing at the pandemic level globally. It's not recognized by WHO. Second, we have weak primary health care systems in many countries. We have weak NCD programs, and in many cases, non-existent NCD programs to deliver services at the community and primary health care level. So my suggestion is the excellent example by Dr. Jagpal and Dr. Altani, why don't we establish this WHO global thing to the ground, establish WHO collaborating centers in Qatar and Mauritius to treat and support Southern Africa and Africa, Qatar to support the Gulf states, so that you have the excellent model can be pushed forward, both politically and financially.
Thank you so much for a very excellent and very specific suggestions. Any would like to respond or?
Okay, thank you, and thank you for mentioning Mauritius and Qatar and WHO. Yes, this is very important. And frank speaking, it's time to change things. We saw HIV was killing people, and some countries decided to manufacture the HIV medicine at low cost, and it happened, and it helped a lot of people to live now average life higher in diabetes, in HIV. The second thing, we have the same hepatitis C. Hepatitis C started that medicine by $100,000, and now it's in Egypt by $200. So we can do miracles. It's happening all the time. So this is something of the cost. Many people needed a lot of consultancy that people cannot be there, but people has trained the people in the rural areas and helped them in many things like mother and child care. They were trained, and now there is telemedicine. So I believe, frankly speaking, with we know it's a pandemic and growing, and the cost will grow. But frankly, we need to take more smart actions that change the game. We are very proud that insulin was created 100 years. Since 100 years, we couldn't make something as equal as the value of this insulin. We did a lot of good things, but not as change the life people will live and survive. So I would like to support this thing that we need to take actions to keep the cost for all the lower income carriers with this artificial intelligence and technology we have, and the lower cost of manufacturing in some countries. Thank you.
Your Excellency.
Yes, probably. I'll just add something that I feel that is very important to look at. Especially in countries where you started having a lot of industrialization, a lot of change in different aspects, especially coming back from a traditional way, farming and so on, and going to other ways of having your income. Now, what's happening? We quite missed up to see that how you've got fast food mushrooming everywhere, and that make a lot of impact, especially in kids, in children, and how that we grow up with this fast food, and at the same time, and say that yes, it's getting a problem to us, but how is the industry pressure, everything come up, and no one take the lead to say that yes, it's time that we've got to address this issue of fast food, of how that impacted especially a lot of diabetes, and it's going to have a huge impact on population in the next 10, 15 years. I'm sure that's going to happen.
Thank you all. I think that given the time limit, I know that it's a very interesting discussion, and we all have to admit the fact that when insulin was used on human trial, insulin was found long before 100 years, but insulin was given the first trial on human 100 years back. At that time, the patent was sold for $1 because they said that this innovation, that this discovery doesn't belong to any individual, but to the humanity. Today, 50% of the people globally do not have regular access to insulin. And if you look at sub-Saharan Africa, only 3 out of 10 people have access to insulin. This is the reality that we are facing. So we have a lot of challenges we can discuss the whole night. And so unfortunately, we have to close and thank the panelists and everybody for your insight. So I think that we move to the next one.
Thank you so much.
I understand. I
on WhatsApp, and that we
understand. We sure. We'll do it. Thank you. Thank you for your time. Okay, we can move to the next session. Time is running out. So please, the next panelist, please sit on the dais, and then I would like to give a kind of that diabetes and well-being is more than access to care, and this has been this is the World Diabetes Day theme of the IDF, and I'm showing you that why. Okay, so first of all, I have welcomed you. I think that we can move this. We have seen the statement from Dr. Tades, and that we have also seen this ministerial panel. And diabetes and well-being, the focus of the 24 to 26 World Diabetes Day campaign. As we know that the diabetes is increasing. As you know that diabetes is increasing, that the figure explains everything. I don't need to see that how it is escalating. Is because that despite of all our innovations, you see that what is happening, that we are patients with diabetes are living longer. which is a good thing because of the new medications that is coming up. But we are not focusing on prevention. So the new in-flight, new cases of diabetes are coming in, and the people with diabetes are living longer. So this situation that this figure is saying that this figure will not be able to change unless we focus on prevention. But this increasing global impact of diabetes, you see that this is the IDF. It is not changing over there. It has moved here. It's not working. So you see that the increasing global impact of diabetes, it is actually not in one part. You see that South and Central America, the SACA, Southeast Asia, 68%, Middle East, and the North African, there's a MENA region, 87%, and Africa is actually 134%. And this is what is going to happen in so you see that 3 out of 4 people with diabetes are actually living or going to live in low and middle income countries where the resources are highly limited. Anorexia, why we are focusing on this thing? Because if you look at anorexia, bulimia, binge eating disorder are more common in people living with diabetes than in general population. So we start from there. That 2 to 3 times, that people living with diabetes is 2 to 3 times more likely to have depression, that we have discussed about this mental health issues. And we see that people living with diabetes and depressive disorders are at 50% higher mortality risk than people with diabetes and no history of depression. We are also saying that the individuals with higher levels of diabetes distress were found to have about 1.8-fold higher mortality rate, a similar increased risk in cardiovascular disease, and lower quality of life. Considering the evidence suggests that diabetes is associated with suicide, intention, and attempts, the risk of suicide death is 1.6 to 3.6 times greater than the general population. So this is the quality, and I'm not touching the discrimination that the people with diabetes faces, because it's very difficult to get any hard data on discrimination. So World Diabetes Day 22 we are focusing on diabetes and well-being, just to say that diabetes is more than glucose, that not only the glucose control is a patient-centric, that the patient, we should be thinking of a human. In IDF, we do not call patient, we say people with diabetes. And this is because we do not think that diabetes is a disease, and you are not a patient per se. You live a normal life. All you need is some support. This 3-year focuses, that if you see this, the 3-year focus is 2024, this is awareness. 2025, it will be the impact, that is to mobilize the audience to put well-being at the heart of the diabetes care. And in 2026, a change built on year 1 and 2 to ensure the lasting legacy on healthcare policy. This cannot be achieved by IDF alone. IDF is raising the issues. We need all the stakeholders to come and join so that we really can see a change here. So raising awareness is demonstrate the impact of diabetes on well-being to a global audience, highlight the life experiences of people living with diabetes and their caregivers, because we must not forget the sufferings, the distress the caregivers faces. You think of a poor man who has to think that whether he will buy the food for the rest of the family or he will have to buy the insulin for his type 1 child. What kind of distress that these people faces. So target audience for us would be people living with diabetes and their caregivers, healthcare professionals, and policymakers, and share stories and ask support with their well-being, adopt people-centric care, They said, we must adopt diabetic-centric care, so we are saying that adopt a people-centric care that supports the well-being of people with diabetes, and made aware of the connection between diabetes and well-being, and change the policies that is required to be changed. So I will not make, as we have seen that we have a discussions panel. Now we will have a discussions panel with the followings: that Dr. Jackie Malouf, the president of DIALEV and IDF vice president; Dr. Mark Baron, the founder and general manager of Intersectoral Forum of NCDs in Brazil and former IDF vice president; Mr. Bent Nelson, the head of Global Advocacy World. Can you raise your hand so that everybody says? Bent? I'm sorry that I didn't ask Jackie, and then Ms. Sadavi Chauhan, that is she's representing the Government Engagement in Policy Management Access of Medicine Foundation. Welcome to this forum. So each of you will have about 3 minutes to give a comprehensive, as comprehensive as possible, given I remember that my professor told me once that when I was a PhD student that Akhtar, try to tell me as much as you can with the fewest possible words. So that is try to tell us as much as you can with the fewest possible words. Thank you. So I will start the discussion with Dr. Jackie Malouf from this president of DIALEV and IDF vice president of the role of philanthropic organization, enhancing well-being of individuals with diabetes and other NCDs, the contribution of diabetes associations and communities.
Thank you, Professor Akhtar. It's really a privilege to be here today with such distinguished panelists. And what we heard earlier was really interesting. So in order for us to respect Swiss time, I'll try to be very brief. I will say that we heard a lot about the challenges, a lot about what's needed to be done. But sometimes we tend to forget that the associations and the organizations who care about the members living with diabetes are at the forefront. They are the soldiers on the ground. They need empowerment. They need support and means and resources, because the doctor's visit has a timeline, very short one. To complement with it, we are here. We are doing our role in order to help. And to start with the background of the theme of well-being, we need to think of it in 2 parts. In order for us to speak about well-being, we need to tackle physical health and mental health. And they are so interconnected and interrelated that one cannot go without the other. They go hand in hand in order to start feeling this feeling of well-being that is really a human right. It's not a luxury. It's not something that we are offering to people. It should be their legitimate right. But before speaking about my experience, 15 years by leading DIALEV, I would like to call your attention to some points that I'm sure most of you know, but we are human. We tend sometimes to forget them, that coping with a chronic condition by itself is a lot to take care of. It's a lot of pressure, and it can create depression, emotional distress, anxiety, in some of the cases, of course, frustration, and most importantly, a feeling of isolation. And if we don't take care of that, we have really a problem. I will not go into the program right now because I will leave the floor for the other speakers, but there are definitely many steps along the way, many programs to follow, a strategy to achieve the goals we have set for the purpose of achieving the so wanted well-being. Thank you.
Thank you, Dr. Malouf. And now I will move to Mr. Bent Lautrip Nielsen. So I hope that I'm pronouncing it correct. and the role of philanthropic organization in improving the well-being of people living with diabetes and other NCDs.
Yes, thank you very much, Professor Akhtar. Of course, on behalf of WDF, we are very grateful to be here. The relation between IDF and WDF goes 20 years back, and we are very pleased to be here. Just before I go to your question, I mean, let's all remind of the importance of this topic that you're raising. You've shown the figures, 500 million people or more. We are in the World Health Assembly Week. Major topics are being discussed just a few meters away. Pandemic, treaty, and all what you have. But with these figures and these projections, we cannot neglect the diabetes burden. And I believe it was last year the Lancet said that diabetes is the defining condition of the 21st century, or in other words, our ability to address our diabetes will be defining our societies. To your question, the role of philanthropy, I think I would respond with the general perception of philanthropy and then the experience of the WDF, the World Diabetes Foundation. Philanthropy is a very interesting group of organizations because you don't have a resolution for the philanthropic work. Philanthropy comes with a mission that's often defined by itself, often driven by equity or solidarity and development of society. And I think in the diabetes response, the role of philanthropy is critical. And you will have to define by your actions. You will have to show that you can commit to areas and processes and activities which can make progress and improvement. And if there's one area where this is really required, I believe it's in the diabetes global response. So that takes me to the history of World Diabetes Foundation. We were funded 22 years ago. And you can imagine where we were at that time with the diabetes and NCD response configuration, the theoretical work, the normative work. There was hardly anything. Nothing was there. We have even partners in the room, Professor Basit from Pakistan and others. We were all starting to grasp what this was about. Of course, there was knowledge about diabetes and clinical guidelines, but as a mass response to a pandemic, as it was mentioned, we were very backward. So what have we seen as the role of the philanthropic foundation, World Diabetes Foundation? I think we played a tremendous role in advocacy and projects on the ground with institutions, many member associations, by the way, globally of the IDF. Many of these associations, we were with them from the beginning and all the way until today and beyond. And that's of course also because the funding available for diabetes care and prevention has been very low. I mean, we have for many years advocated towards bilateral donors, banks, other traditional streams of funding to invest in diabetes care and prevention, and the progress has been very weak, unfortunately. So obviously, we have been marched on and on with our grants. I think today we have funded more than 200 million euro in programs in many countries. And some of them have become national NCD response, you can say, platforms, where diabetes is very much at the center. So obviously, I am biased. I think the role of philanthropy is extremely important, but philanthropy cannot be the response. It must be the catalyst for a response. Philanthropy must be taking risks that others are not taking. And philanthropy must also be showing the accountability with the individual people living with diabetes. I think we have in our mission statement, which was formulated 20 years ago, alleviate the suffering from diabetes and its complications. And the mission statement is something around improving diabetes care and prevention, full stop. We have kept those phrases there for 20 years. And I think they're still very, very relevant. But obviously, we have to get a global response. The Lancet says it's the challenge of the 21st century. And it's not just for philanthropy. We are just a small part of it. Governments, and we had a great panel before showing commitment. And the good news is we do see that commitment happening. But we are at the final hour. This wave is much higher than we think. And you have shown those data, and we have, of course, also success stories of progress, and we have the Global Diabetes Compact. So there is hope. But I can only say we are, as a philanthropy, and I would also raise the flag for national domestic philanthropies to really come on board and push those agendas forward with investment and with the advocacy work. And again, today is a good example. We have a possibility to show progress is there. It was a call upon regional centers of excellence, and we know this is work in progress. And thank you again, Professor Akhtar and IDF, for the opportunity.
Thank you so much, and I agree that it is the joint responsibility of all. It's not only the civil society, the government, philanthropy, industry. So it is a kind of common responsibility of all, and we cannot run away from these responsibilities, because today we see that, as we are saying, that if this tide grows as the way, no matter whether you are rich or poor, you will not be able to cover this expense over a long time. We are seeing the countries, not only the poor countries, we are seeing that even the rich countries are actually struggling already with the burden of diabetes and diabetes-related complications. So it is in our, and we know that diabetes is not a disease. This is also a issue of development, because people in the poorer part of the world, we see that it is happening at an earlier age, and it is halting the economical growth in these countries. So diabetes also should be seen not only as a disease, but also an issue of development. So thank you, and now I'll move to Dr. Mark Baron. He is representing the Intersectoral Forum of NCDs in Brazil and the former Vice President of IDF. Enhancing well-being for individuals with diabetes and other NCDs, the contribution of diabetes associations and communities.
Well, thank you very much, Professor Akhtar, for the invitation, IDF. So I'm gonna first start by sharing my interests here, that I won't say conflict of interest, I would say my good interests here, because I'm a person living with type 1 diabetes for 33 years. Besides, I have diabetes type 1 and type 2 running in my family for decades, and I have so many friends living with both types of diabetes. So my interest is that diabetes, we see better numbers for diabetes, we see less premature mortality caused by diabetes in the world. And what I would say is that for that, we need people participating. We need meaningful engagement of people living with diabetes in all the decision tables, in participating in politics, deciding the policies that will be implemented in their countries with their policymakers. This is fundamental. How can we decide what people need if they are not participating, if they are not engaged? This is key if we want to see better numbers, but also, as we are discussing here, well-being for people living with diabetes. And unfortunately, well, it was excellent to see examples here of countries that are truly engaged, that are doing amazing job. So with the care of diabetes in the regions where they are, but unfortunately that's not the reality of many of the countries. So deadly decisions are still being made globally, which is, for example, not making insulin and strips available for free for people living with diabetes. This is a death sentence. This is unacceptable. We cannot continue this way. Besides, blaming people for not making healthy choices. It is, obviously, we all have responsibility for what we do. We all should engage the organizations, people, as Professor Akhtar just said. But if also the policies are not planned in order to lead to this healthy society, it will be difficult. So if we keep taxation low for tobacco, alcohol, sugary drinks, ultra-processed food, how can we later blame people not having healthy food? That is a very challenging thing, right? So I would just like to finish emphasizing what Bianca has already brought about the Global Diabetes Compact. And the member states should commit with the Global Diabetes Compact. And I'm gonna highlight one of the targets. That is 100% of people living with type 1 diabetes with access to affordable insulin and blood glucose monitoring. So, which again, it's unacceptable after more than 100 years of discovery of insulin that this is not reality, that this is a target for 2030. That this should also be reality nowadays. But unfortunately, it's not. And I would say more. According to T1D Index, 1/3 of people living with type 1 diabetes that should be alive are not. So we would need to have another block of chairs here, because there are only 2 that would be the 3rd. But no, they are unfortunately not here. They die prematurely, people living with type 1 diabetes. That's very serious. And how can we continue this way? And this affects me very personally also, because as I said, I have many friends living with diabetes. And every year, sometimes every month, I hear of some of them dying with my same age or even younger. So, and I can share that 2 days ago, one friend died. Not only in my country, in several countries I have friends, but that's not what I want to continue seeing, what I want to continue hearing, obviously. So then I think that at least there is no other way to at least the countries to commit with WHO essential medicines and diagnostics list. I think it's the basic, the first step. But obviously, there is more that should be done, and people living with diabetes should always be invited to take the decisions, make the decisions together with policymakers. Thank you.
Thank you. Thank you, Dr. Baron, for sharing very insightful and people living with experience. As you know, that IDF tried to take a resolution that Dr. Bianca is aware of universal access to insulin, a WHO resolution, which was placed not 2 years before. Unfortunately, some countries, I do not want to go by names, didn't like it, stopped this resolution. So IDF is very much in favor, but as you said, that many times we feel helpless because those who are supposed to reach, they seem to be the obstacle. But we should not give up. We should fight. We should keep our fighting. Thank you so much. So I will now move to Mrs. Shadavi Chauhan, the policy lead for Access to Medicine Foundation, Access to Diabetes Care and Wellbeing. Please.
Thank you, Dr. Akhtar. Good evening, everybody. I don't need to introduce myself. I work with the Access to Medicine Foundation. Before I start talking about my intervention, I just want to say thank you for sharing your personal experience, Dr. Barone. And I think all of us in the room can agree that we have been touched by a diabetic loss in one way or the other. So we all come from a place of passion in addition to our professional position that we hold. And I'm very sorry about that once again. What I want to start by saying is that access, in my opinion, is central to the well-being for people living with diabetes. I heard something at an NCD event yesterday, which I think would resonate with all of us here, where a patient advocate of a kidney disease said, a lot of people suffering with NCDs do not want to get a diagnosis unless they have assurance of treatment after. And central to people getting treatment is access to these products. And what we at the Access to Medicine Foundation have been doing since 2008 is we've been closely following what the pharmaceutical companies are doing in terms of facilitating access to the products for especially low and middle income countries. As it was stated earlier, these are the countries bearing the highest burden of disease when it comes to diabetes. what our report has found. We published a report in 2002 where we saw that 3 leading pharmaceutical companies are in charge of 90% of the market value of insulin. These are namely Eli Lilly, Novo Nordisk, and Sanofi, which a lot of you in the room might already know about. They also happen to hold 83% of the insulin being utilized in low and middle income countries, and they have a 95% market share of the insulin being sold in these countries. What I'm trying to tell you by these numbers is that these companies have great capacity when it comes to facilitating access to diabetes-related products, not just insulin, but also monitoring and delivery devices. However, they're not doing enough. And to substantiate this statement of mine, I would like to share that our research found out that out of the 108 countries that we were analyzing in our report, 24 countries did not have a single insulin from these companies registered in them. While I know that in some cases, countries tend to forego registration by having import favors, what I need to emphasize is that pharmaceutical companies have a responsibility towards delivery of these products, and the first step that they can do towards this is to have their products registered. And this is not just for human insulins, but analogs as well. And what we saw when it came to analog insulin, the numbers were even more dismal. In 27 of the low-income countries that we were analyzing, 15 had no analog insulins registered. So not only is this depriving patients a right of treatment, but a right of choice of the treatment that they would like to pursue. A second problem that I think pharmaceutical companies need to address urgently is in terms of affordability of these products. We all know that in some instances, patients in low and middle income countries are paying way more for diabetes products than even middle and high income countries. And this is unacceptable because we know that a lot of these countries do not have public funding for these products, and people are being forced to pay out of pocket. With having said that, I do want to acknowledge that our research found that companies have tried to support affordability through strategies like price ceilings and donation programs. But what we found is that the strategies have been fragmented, and more importantly, they're not sustainable in the long run. And this is something that we want to continue pushing the pharmaceutical industry to do, is to pursue strategies which is sustainable, not just for addressing the issue today, but also 10 years down the line from now. And lastly, I believe it's very important for companies to have integrated models, not only because these help with the sustainability of financing, but they also help initiatives get integrated with the existing national healthcare strategies, which I feel is important to improve healthcare delivery at a national level. So with that, I just want to state that we at the Access to Medicine Foundation believe, like it has been stated, that it's not alone for the pharmaceutical industry to solve this issue. It has to be done in alignment with the government, with the local community organizations, philanthropic organizations, as we all are representing here. But they are central to the solution, and they should be called on for taking this responsibility, and that's what we continue to work towards. Thank you.
Thank you, Ms. Chauhan. And so I think that we have raised some issues, and just to say that, for example, yes, you are absolutely correct that actually medically is unethical when you diagnose a patient, but we cannot provide the care, the treatment. So if we cannot provide treatment, we diagnose, it's actually unethical practice of medicine. So that's the core, and that I think that all people in the field of medicine must have this kind of dilemma. The other thing that I would also say that Mr. Baron, or Dr. Baron, that you mentioned about the voice of the people with diabetes, and which is, I think, is very important. But at the same time, my question, I was telling to one of my friends who happened to be the minister of a country X, who is also diabetic, that I said, do you have any problem with your voice? People are listening. What you have done to make the voice from the people on the farmer, a peasant in a country that he is suffering with his own family alone, what you have done to secure your voice, his voice, not that you will use this term in order to secure your voice. You had enough voice. We have heard enough of you. But question is that how do you secure the voice of the people with diabetes who are voiceless? And this is the question that I think that we need to take. And one of our friend, I think that he's passed, who made a comment that Akhtar, that you know that we went to war in Iraq to find weapons of mass destruction. We didn't find any weapons of mass destruction, but weapons of mass destructions in every street corner. That is all fast foods. They are killing more people than any weapons of mass destruction ever did. We are not controlling, we are not promoting them. At the same time, we are going to war in order to have the weapons of mass destruction. So we are in a kind of dilemma. As when I was a medical student, somebody told me that you wake up the patient to give the patient for a sleeping pill because the doctor prescribed the medical pill. So the patient was sleeping. The nurse wake him up to give the medical pill because she's supposed to give the medical pill. So you see that we are in a situation that there are a number of issues. I think that our time is running. Instead of I am asking the questions, so that I'm opening the floor, that way that the floor can give this question to our panelists. Yes, we have. I think that you raised your hand before, so I think that I will give you the floor first to her, because she's waiting for the last time, and then I have recognized. Yes.
Hi. I will present myself first. I'm Lucia Rodriguez. I'm from the Ministry of Health of France. First of all, thank you so much for such a thrilling session. I think it's a subject that we're all very much passionate about, and we need to keep moving forward with it. I wanted to, first of all, obviously salute all of the efforts that have been made towards care that's accessible to all. I think I do agree with all of you in the sense of which we cannot allow ill people to be dying because of lack of treatment, because of lack of access to treatment. France has obviously full refunding of the treatments, and obviously we promote this, and we would be very much happy to exchange about this. I wanted to address something about the fast food and the food environment in general real quick, because I know the time is running. But right now we're treating our patients and putting them back on the same environment that actually made them sick. I think there's a lot of things that we can still do. Taxation is one of them. You spoke about this. But what are your thoughts on front of packaging policies, because in France we have the Nutri-Score that has been proven to actually improve the choices of people that when they go buy food, and it's actually one of the single processes that reduces the gap in socioeconomic settings with people who have a lower socioeconomic setting, making better decisions and reducing that gap. What are your thoughts on that? Do you have any experience of that or any return on other countries' experiences? Thank you.
Band?
Yeah, I think this is an excellent comment and remark, because it's at the very core of the matter, the prevention, because we are not talking about simple political processes. Yeah. These are major reforms of the way we produce food, the way we trade food, the way food is marketing, and progress is slow, but it is there actually. You have countries where you have endorsed legislation around front package, as you mentioned. We do see, although it's still very little, we do see multi-sectoral progress, where it's not only the Ministry of Health, but it's more sectors of society and government. Because at the end of the day, we can't change this tidal wave, or whatever we call it, without a much more fundamental change. So I really appreciate that you took this up, because sometimes there's a tendency to talk about access to care and well-being, which is obviously something extremely acute, with 500 million people and less than half in proper treatment. But while we address that major challenge, we have to look at those societal, systemic, fundamental changes. And that requires much more than even WHO, the NCD department, although we are a big admirer of the work of the compact. It has to go beyond that into something multi-sectoral and political. And that's why we can also have to take it to heads of state and government. But at the same time, the push must come from civil society and the association members of IDF and all those related fields that are not only for diabetes, but a much broader spectrum of civil society. Thank you.
Thank you, Bent. I think that
Can I
I think Jackie, Dr. Jackie. I'm little Scandinavian because I lived all my life in Scandinavia. We are very informal. We don't say professors, doctors. We just call. Even my student tell my first name. So I'm just saying the Jackie and this. So please excuse me. I should be a little more formal. No, I said that since our time is running, so please respond. 1% respond for one question, and then we have a second question. Can you respond with that one?
But I need to add something because it tackles civil society. Okay. And first of all, I want everyone to know that I'm also from the perspective of a mother of a young lady living with type 1 diabetes. So whatever you, all that you said resonates to me as if it is my own. So I'm sorry about your loss, and we see this really happening every time. I want to say that, yes, we have a civil society, a strong role in what you are saying, but for that was my call to action. We need empowerment from our governments because we cannot do it alone. The government cannot do it alone. We are the people who visit schools for awareness purposes, but then what happens, we finish our awareness visit to the school, the kids go to the cafeteria, and what do they buy? So I sent a proposal years ago to different ministries, because here we have the Ministry of Education, the Ministry of Health, the Ministry, well, several of Youth and Sports. If all of them combined empower the civil society, then we can, yes, make pressure on schools to check on their cafeteria, to send nutritionists, to send a specialist to check what they are selling to our kids after we give them the awareness talk. So it needs a combination, it needs a holistic approach, and it needs support from all the stakeholders. One alone cannot do it. We have the responsibility, we acknowledge it, but yes, we need our government support. Some governments are doing it, some are not. Thank you.
We can, thank you, Dr. Jackie. So we're going for your questions. This lady on this side, the last, and then Abdul Basit, I think. Yeah, please.
Hi, sorry. Hello. I almost dropped dead actually from type 1 6 years ago in Switzerland. Like a skeleton, I was undiagnosed because as an adult. But actually, I think last year, was it last year? I remember you were there. Yeah, there was the diabetes event in the ballroom here, sponsored by the IFPMA, talking about access to medicines. Because in the end, and I have to say, I did work years ago on access to medicines for HIV, you know, which set the language on this whole issue. And now what the pharmaceutical companies have seen is that this is great. Let's use all these patients that the doctors don't dare to say, you're overweight, you need to lose weight, how can we help you? I'm lucky that in Switzerland they told me that, right? They're like, now, yeah, not I was overweight, but you have to do this, do this, do that. And my fear is that, you know, there's been too much focus on access to medicines, and it's quite possible now that when it's refused in the WHO, it's because it's amalgamating everybody with type 2, many of whom could just get better by doing exercise and cutting down if they had access to good food, you know, where they live. And I was just wondering how you see, because even the WHO, I think, sent an ADG last year. And it's great to see there's a medical officer, but you know what I mean? We're in a tiny room now because we're talking about prevention. And so I'm just wondering, you know, because the drug companies have a lot of money, let's be honest, so does the fast food industry, and they're the ones pushing for people to not prevent, to not eat properly, to eat crap, and to take more drugs. I mean, just one other thing. When I asked the doctor, the head of the University Hospital in Geneva, I said, how many units of insulin does the average, the worst patient in Switzerland take? About 200 units. Then, if you look at in America, where they have, it's woke society, you're not allowed to tell anyone they're overweight, you know, American crappy food is great, you know, and so what do they say? I'm looking on the insulin train activist things to Canada, where they're going to Canada to get insulin, and you have these GPs saying, American doctors saying, my average patient needs 200 to 300 units of insulin a day. Why? Because they're drinking Coke, no one's telling them. So I'm just wondering, why is this room so small that we have no one talking about prevention, and not even WHO hasn't sent, an ADG? But it's because we're not talking about drugs. Sorry, but how are you going to get support for prevention?
Thank you so much. You have a very good point. As many of us have already mentioned, I think in my talk, even though this is not the topic I mentioned many times about the prevention here, but yes, nobody is investing. Honestly speaking, it is not only the industries to blame, it is also my own profession. The medical community is also one of the barriers. Because the medical community says that their treatment is my job, not prevention is my job. So treatment and medication, it gives me money, it gives me my professional practice. So it's a medical professional, you can say the medical establishment, industrial establishment, all we need to address. But at the same time, you can say that, as you have rightly mentioned, in the United States, why the cost of the insulin price is highest in the United States compared to anywhere else in the world, because the government failed to control the prices, because of the free economy policies, right? But aren't they see that what is happening to the patient? Because if you look at these type 1 patients in the United States, many people are not within the insurance, and those people, if you look at the rate of ketoacidosis in the 18, 19 years old of type 1, is one of the highest is in the United States. So the rich countries, unless the policies, proper policies, the government is engaged, we see that even the rich countries fail to provide the support they need. So as I said, that it is a kind of common responsibility. It is a common responsibility of our medical professionals, the civil societies, the industries, the government. So we all need to get engaged, but it says that one thing is to say, the other thing is to do. That's the reality that we have here. We are the people actually in this room at the moment that who are all committed to diabetes. But if you talk to the health ministers, their excellencies, they deal all kinds of communities. They are sitting here in this room or talking about diabetes. Next meeting, so they are going for oral health, right? So this attention is being diverted. So, but unless there is a commitment, firm commitment by the government, it's very difficult to do. The global bodies like WHO is important because the government listens to the WHO. Government doesn't listen to IDF. Government listens to the WHO. So WHO has a very important role in terms of shaping the policy. So it is a wider discussion. And Professor Abdul Basit,
first of all, thank you, IDF, and thank you others to let us come along here on this important topic. My small comment and request is for Bent from WDF. We have known each other for a good 20 years. They are not only a philanthropic organization, but when they gave us projects for diabetic foot or for insulin in type 1 or for GDM, they made a condition that it has to be sustainable once the philanthropic project is withdrawn. So for example, they sustain us for 3 years, but then it's our job to make it and convert into a sustainable project nationally, which we have been doing for so many projects. The small help we need now is when time has come that national level projects are being delivered, but we are not able, still not able to mobilize the public sector, the ministries, etc., to have non-communicable diseases or diabetes as a priority. We need high-level meetings, advocacy meetings. We need budgets for intersectoral meetings. And now the WDF has made a strict line that unless you have got the government involved in the project, they will not be able to fund it. So we just request that in those countries where there are people, 33 million people with diabetes, it's still not been able to motivate the government into action. Can you just help us out, or anybody in the house help us out?
I will not make any comment because officially I cannot make any comment. People say that every country has a government, but Pakistani army has a country. So it's opposite side. So the government needs to be stabilized. But yes, unstable government is the biggest threat. But as I have said, that the challenge is many, and because of the time limit, Dr. Abdul Basit is very, very important, that we are talking about sustainability, that any initiative that you can take, that sustainability is not secured. But one thing is true, that we see the progress. You see the progress that, but until today, I think Dr. Bianca is here, and if you look at the OECD countries' contribution to not only diabetes, NCD as a whole, is still less than 10%. Is still less than 10%, and this is something that we need to address. That NCD as a whole, that the OECD countries' contribution. So if you see that it's still a long way to go. Bent, just short comment, please.
Yes, I believe, Professor Bassett, you put us a little bit on the spot, to say the least. So I'll just respond quickly and say very honestly that you're right. We always said from day one that with the grant we had the ambition that whatever was made at country level would lead to something sustainable. I think among us in WDF we knew it was not easy. It was more a hope, but also an advocacy appeal that the results that leaders like yourself could manage to make happen in often complex contexts could lead to that seed of political commitment, of investment, of national health budgeting for diabetes, of better access to care, of community involvement, of awareness raising. And I believe you have been given more than one grant, Professor Bassett. So you will see we were also very aware that the aspiration we gave very openly was not a very, we were very pragmatic. And we still are, I believe. We try to build the best possible alliances now. We adhere very much to the wonderful and very needed WHO Global Diabetes Compact, and through that bring other funders, organizations together. And I believe one day World Diabetes Foundation might have achieved its goal, but I'm sorry, we still have a lot of work to do. And we will be with all the countries we can. We will mobilize all the resources we can, but we will not do it alone. We will find alliances with all agencies, civil society, World Bank, the broader and the more inclusive, the better our hopes will be.
Last comment, Dr. Baron.
Yeah, I would just like to mention that, first of all, the social participation, what is the name? The resolution will be presented tomorrow, so hopefully it will pass, and then we hope that civil society will have more voice with the governments, so then you can bring your advocacy and have a seat on the table always, and participate in all decisions as in all the other countries. That's what we hope. And I would mention also about, since it's being discussed about prevention, that in Brazil we have a very successful program of prevention of related to tobacco, and to achieve this, so different strategies were used. So labeling, so prohibiting propaganda, increasing taxation, so different ways, different strategies together to make this possible, to make Brazil a model for this. And now we are discussing why not transfer this to other products. There are risk factors as well. So why children see propaganda? Do we see propaganda of lettuce, of apples, of bananas on TV, and what is the price? So also we have been discussing subsidizing the food. There are healthy food, and to conclude, we have also started to have policies to forbid to offer or to sell ultra-processed foods in schools in Brazil. So we have this already implemented in 2 large cities in the country, and we wish to spread throughout other cities and hopefully in federal level as well.
Thank you, Dr. Barron. The last question is coming from the audiences there's 2,000 audiences that were online. And then I will read the question first. The community engagement in diabetes care and empower people living with diabetes. What measures are needed to ensure patients' involvement in diabetes care and self-management? Dr. Jackie, can you start with that?
Yes, actually, it all comes back to the program that the associations implement to involve people living with diabetes. I want to thank the audience online, and especially those who are living with diabetes, because if we are here, it's because of you, and we are here for you. This is the main umbrella of all our work. When we do the support groups, it's for you to have a safe space to speak your problems, to have the peer support much needed for your well-being, and to ease the mental health burden coming from the management of the disease. When we speak about diabetes self-management education, and we do the sessions and we educate even the professionals in relation to diabetes, it's when we have in mind the well-being of the people, because by empowering them to themselves manage their condition, they would feel self-confidence, self-esteem would go sky high, and they will be much closer to that beautiful feeling of well-being. So the programs that the diabetes organizations or other NCD organizations are implementing, especially in closed doors, not necessarily publicized, not necessarily posted anywhere, this is for the well-being of our members. And I want to thank the person who asked the question, because really this is the reason and this is the core of our objectives. It's to make them have a better quality of life. So much we speak about the QOL, the quality of life. So much we hear about well-being, about so many nice things. But what we need to do is to implement our programs, to be empowered and have enough resources to keep implementing our programs to ensure sustainability. Because once we do those groups, by themselves, they will be the mentors and the trainers for the other groups, especially those recently diagnosed, those who are lost in space, those who are asking, why me, why now, why diabetes, why my family, why this, why that. We need to be there for them, and that's why we empower those who are now living with diabetes, for them to be able to support the coming ones, not without mentioning that, yes, it's extremely important to work on prevention, but you all know that with type 1, this is not the issue. We can prevent type 2 diabetes, and we are working on that, but unfortunately with type 1, it's not the issue. Thank you.
Anyone else from the panel wants to add anything? If not, I think that this is actually closing the whole discussions, because this is what that empowerment. That it seems that there are 2 points. I think that, in my opinion, empowering the people, because it seems that we who are supposed to help our communities, we are failing to a larger extent. So unless they raise their voice, question is again that question that I raised before, that how do we secure the voice of the people who are voiceless? And that is the biggest challenge. And how do we make the media, because the politicians listens to the media, how do we make the media more attentive to this cause? Because media is also think that what they can sell. So this is a kind of product which should be sellable, so that the media could be attracted to these points, because this is very important. I see that the positive things that I see that it happens is that there's a movement. At least now there are discussions. I remember that I wrote even in the Norwegian Medical Journal together with my Professor Jacques Jarbel, who passed away, who was the past president of IDF. Together with him, we wrote that what is the global health in NCDs is that they called 3 diseases, the diseases of poverty, the diseases of poverty, and these three diseases: malaria, tuberculosis, and HIV. So that's the whole about the global health. So you see that it's but from there, at least now diabetes has become included actually in the global agenda. So we are saying that there is a progress. So we have a hope that things are moving, even though it is slowly moving, then we hope. And the responsibility, as I said, that belongs to all. With these words, I think that I would like to move towards our closing remarks. That effective partnerships among all the stakeholders are necessary to break through the barriers to well-being. That I think that what we discussed today, a joint responsibility that we cannot deny. And that we should remember that this is a joint responsibility. It is not only the responsibility of the IDF or any individuals, but it's a joint responsibility of humanity. As Mr. Bent has referred to the Lancet comment, that diabetes is a challenge of 21st century, whereas it is not only a challenge, it's a question of humanity. We are seeing people are dying. We're seeing the parents. I have seen a father who was relieved when his child died, because now he will not have the guilty consciousness of not buying food for the rest of the family. So this is what we face. Those of us, because I lived in a poor country and in a rich country, I see that if you give free insulin to the people, they sell in the market. They sell in the market simply because that they have a logic. That if I don't use insulin, I will maybe die in 2, 3, 4 years' time. If I don't eat, I will die in 7 days' time. They have a logic. We need to tackle the poverty issues. When we're talking about access to insulin to all who needs it, we cannot avoid to tackle the poverties. And that is important for us to remember. And I would like to express my thanks. And I'm honored to have, IDF is honored to have all the people and all your comments for this and all the support that you have given to IDF and for which IDF is engaged. And IDF is doing all it can do. I hope that, but IDF alone cannot do it. One national government alone cannot do it. WHO alone cannot do it. But we need an effective partnership. And other message that I would like to give, that IDF is going to have the World Congress in next April 8 to 11 in Bangkok, city of Bangkok. We'll be discussing this more in details, not in 2 hours time, over 4 days. So we'll be presenting all scientific developments, and also this time we are also opening up a session from all our regions. We do not need the rocket science. We need to hear that IDF has 7 regions, how people with diabetes are living in these regions, and that we need to hear. And that is also we are opening up. Of course, we have the scientific sessions, those of you who are interested, but also that for example, people living with diabetes, we have one session, one stream on people living with diabetes, and we have one stream from 7 regions that they can present how people are living in those countries. So I hope that most of you will join. Without your presence, the global voice for people with diabetes will not be reached, because most of you who are sitting here are the policymakers. So you should listen to what people want to say. Thank you, and thank you for a very wonderful evening with all us. And as you said that we are so, merci, thank you, gracias, shukran, tak, dhanyabad, danke. For you.